episode of This Is Your Brain on Drugs Psychiatry podcast with your host, Dr. Cody Armstrong. This is the second episode that I'm recording. I learned something from the first episode. The slides did not go through, so I apologize on the YouTube. You only see me, you don't see the slides. But the slides on the first episode are just an overview of the show, so not a huge deal. The slides for this episode are going to be much more pertinent and useful, I think, for people to have. And so if you want to follow along with YouTube, hopefully that's going to work this time. So I'm going to start off with antidepressants. These are the most common medications that are out there from a psychiatric point of view. They're medications that every profession uses. A large percentage of the population is taken, and I think that people will be most interested in this. So I'm going to kick it off with this. So let's get started. So let's do an overview, and this is just a map here of the prevalence of depression. I'm not sure how relevant this is. I think what you're seeing here is there is a stronger levels of depression in some of the Appalachian states, some of the southern states, but really depression is pretty prevalent in the country as a whole, in the US, where I am from and the episodes are coming from. So, and it's on the rise and amongst all age groups. And especially we're seeing a lot amongst kids. So, depression is a huge problem in the country and in the world. So I want to mention some of the comorbidities. So depression is a big thing, but you're going to see anxiety with that. You're going to see PTSD and depression have some overlap, a lot of your substance abuse disorders. So a lot of your psychiatric disorders are going to overlap with depression and medical disorders to a large extent. So I've dug up some studies on cardiovascular disease because there's a huge overlap with cardiovascular disease and depression. So depression actually confers a 3 to 5 times increased risk of cardiac related death at 6 and 18 months after having a heart attack. That's pretty huge. So if you've had a heart attack, you know someone that had a heart attack, their risk of having depression is significantly goes up after that. All right. And so in a study that was done of 51,000 patients who suffered a stroke, patients diagnosed with the mental health illness 1 month after the stroke had a 33% greater chance of dying within 3 years, even though they were younger and had fewer chronic conditions. So what that's basically saying is you've had a cardiovascular incident and you have depression. So not everyone does, but for those that do, their chance of dying after that stroke, if they have depression on top of it, is significantly more. And I think that makes sense to everyone. But I mean, to see that 33% greater chance of dying within 3 years, that really puts a pretty big number to it. So, in another one, a third of heart attack survivors experience depression versus 1 out of 20 adults in the general population. So 1 out of 3 heart attack survivors versus 1 out of 20 in the general population. That's a huge difference. Okay. And in women, the symptoms of depression were 50% more likely to develop or die from heart disease than those without such symptoms, even without history of heart disease. So that was another study. And then just looking at some other disorders, I think, those of us in the medical field, we're pretty familiar with this kind of stuff. Inflammatory bowel disease, pain disorders, cancer, neurological disorders, autoimmune disorders, fibromyalgia, even metabolic syndrome. I'm going to do, I think I'm going to do my obesity medicine lectures next because it's such a hot topic right now and it's just so related to so many things. So those with metabolic syndrome, greater chance of overlap with depression, diabetes, dementia, migraine headaches, all those we're seeing in greater amount and comorbid with depression. So, and there's a lot more. Those are just some of the big ones, and those are some of the most common ones. So, let's talk a little bit about the epidemiology of depression. So, lifetime prevalence of depression is around 15%. I've heard higher numbers. I've heard up to 25%. So that's like 25% or 15% in this statistic that I had here of people in the United States are going to have the diagnosis of depressive disorder in their lifetime at some point. That's pretty high, right? I mean, up to a quarter of people. I mean, that is a pretty big number. And so it could be as high as 25% in women, I saw on some other research articles. And women have a greater risk than men of having depression. So that women tend to have more likelihood of getting depression than men. Although with men, it's often more severe and more devastating. So we'll talk about that a little bit later when we talk about suicide. So also the incidence in children and adolescents, as I mentioned, is going up. The mean age is around 40, but I don't, that's just it really covers, and I think 40 is kind of the average age of a human being. So we're seeing a lot of it through all the years of life. And it's more common in those that are divorced or separated. It's more common in rural areas. It is often underdiagnosed in minorities, and the prevalence isn't associated with race or socioeconomic economic background. So, what we're saying there is we're not seeing a big difference between those groups, but we think that it's the same rates across race and socioeconomic background, but we're not getting those numbers. And I've got a chart on that a little bit later. Um, and amongst the unemployed, they're 3 times more likely to have a major depressive episode. And 40% of patients with major depressive disorder also meet criteria for dysthymia. So this is a slide here about the rates in the world, which I'll touch on briefly. So close to 1 million lives are lost every year on Earth due to suicide. I think I looked recently and it was around 800,000. So that's around 3,000 deaths a day. And some of the highest rates are found in Central America, Central Asia, and Southeast Asia. And if you look this up, it's not a country per se, but Greenland actually has astronomically higher rates of suicide than anywhere else on Earth. It's number one, and number two is not even really close. So some of those northern areas of northern Canada, Greenland, have particularly high rates. But generally, rates are high and rising across the world. And what's the cost of depression, right? When you compare it to a lot of other illnesses, it's actually comes out as like the highest. And I mean, it's a little hard to estimate these sort of things, but we're looking at like the medical costs, the costs of the medications to treat it, the costs of folks are not able to show up for work or school or their occupation or whatever it is that they do. And then a big one is something called presenteeism. And so that is they actually did show up, but they're not operating at full capacity because the symptoms are slowing them down, making them less effective. And when you look at if you're looking at the chart on YouTube, what you'll see is that depression and obesity actually have the highest rates of the presenteeism, and then anxiety being the third highest. And those are all, two of those are mental health disorders, and then obesity I feel like cuts across everything as well. And so when you try to estimate all those costs, what folks are coming up with is that depression is costing the most. And the particular chart I have here is several years old, but it's come up with $350,000 there. So moving on to the course of the disease. Okay, so how does this disease of depression kind of, what's its course? How does it start? How does it go on? How does it finish up, come back? So in general, mood disorders, depression being a mood disorder, have long courses and frequent relapses. So we're seeing that these symptoms, they tend to be chronic in nature, and when they do get better, there's a tendency for them to worsen again. So in 20 years, the mean number of episodes that somebody who gets this, they'll have 5 to 6 of what we'll call major depressive episodes, and I'll talk about what that is a little bit later. But that's a lot. And so it tends to happen again and again. And if we have an episode that's untreated, so we're not giving the person treatment, they're not seeking treatment, and we're not just talking about meds here, we're talking about any kind of treatment. Episodes on average last between 6 to 13 months. That's a long time. And especially when you consider someone might have 5 to 6 episodes in 20 years that they last up to a year each, that's a significant amount of somebody's life. And when the episodes are treated, on average, that cuts back to 3 months. So still pretty long. And I think those of you that have treated this know we can't get folks better quick. And I mean, I think 3 months is, wishful thinking, but it certainly is going to last less long if they're treated versus not treated. So, what are the risks of recurrence? The more episodes of depression you have, the higher the risk that it's going to happen again. So, if you've had one episode of depression, there is a less than 50% chance that you're going to have another one. If you've had a second one, that chance goes to up to 50 to 90% chance you're going to have another episode. 3 episodes, and you're talking about more than 90% chance. So if you've had 3 episodes, chances are you're highly, highly likely to have another episode of depression. So as the disorder progresses, episodes become more frequent, more severe, more resistant to treatment, and last longer. So just worse, 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 worse. So that's why it's so important that we get ahead of this and treat it as soon as possible, so that, because when it more resistant to treatment, so we're talking there, like if we don't treat it sooner, the patient is less likely to even respond to treatment. And so it's so important to get ahead of these things. And then we're talking about dysthymia. Usually folks that get dysthymia, and that's a little bit different than depression. For those that you don't know, dysthymia is the symptoms of depression that tend to be a lower frequency, like lower severity of symptoms. So you don't have quite as many symptoms. Your functioning is not quite as bad. It's not quite as severe, but they last a lot longer. And so dysthymia, folks that have that, they often go 10 years or longer before they even seek help. And also, dysthymia is notoriously more resistant to treatment. So only 10 to 15% are in remission a year after they were initially diagnosed with dysthymia. And of course, dysthymia is an older term. It's now called persistent depressive disorder. So kind of a little bit of a replacement there for those of you that maybe have heard both terms. They do mean the same thing, but we now call it persistent depressive disorder. And only about 25% of those diagnosed with this come to a complete recovery. So a lot lower. So what are some good prognostic factors? So these are things that if a patient's got this, that they're more likely to get better, right? So history of solid friendships during adolescence, stable family functioning, having a generally sound social functioning for the last 5 years, absent of comorbid psychiatric disorders, including things like personality disorder, So we don't have like other stuff going on. It's just purely the depression. They're more likely to do better, and then no more than one hospitalization. And that makes sense. But those top three are all kind of related to social support, family support, friendship support. So people that are isolated, people that don't have as good a support there. Um, I mean, it makes sense that they wouldn't do better, but like that's huge. If we can find ways of strengthening those, and psychotherapy is a great thing to do to work on those things. If we can make those things better, it's going to make a huge difference to the patient having a better chance of recovery. And so, what are some poor prognostic factors in depression? So, longer episodes, if they have psychotic symptoms, psychotic meaning that, they're not they're not sensing reality as you and I do. They hearing and seeing things that maybe aren't representative of what reality is. So having those psychotic symptoms, having poor premorbid social adjustment. So they don't have that good social support. They have difficulty engaging with others and informing good close social relationships. Males have a worse prognostic. Uh, they tend to be more stubborn to recover from, and when I say stubborn, I don't mean that they're stubborn, but the symptoms are more stubborn to respond to treatments. Having the dysthymia on top of depression, so you can actually have both. You can have the persistent depressive disorder, and then you can have the major depressive episodes on top of that. So if you have that kind of underlying simmering low level depressive symptoms, in addition to sometimes you go into these episodes where you have the worsening of symptoms, those folks tend to do worse. Substance use issues, so alcohol, drugs, these sort of things, people are using these things, they tend to do worse. And then having anxiety on top of depression, or like an anxious depression or something like that, so just having comorbid symptoms, that's going to be worse as well. So if we can work on eliminating those, making those things better, that's going to help the patients a lot. So I want to talk about suicide just a little bit. I'm not going to go too much into it. So when you're looking at men versus women, women are 3-to-1 more likely to attempt a suicide, and men are 4-to-1 more likely to complete a suicide. I think a lot of people have probably heard this. Women do have a tendency to make more attempts, whereas men tend to use more lethal means. So men are more likely to use firearms, women are more likely to use medication overdoses, and firearms are extremely lethal in the rates of 90+% depending on what they used, versus medications are more in the maybe 5 to 10% range for lethality. And so if you look at here, so men 57% when they attempt suicide use firearms versus 32% for women. Suffocation, it's about the same, 23 to 20%. And then poisoning, so poisonings are overdoses, 13% for men to 38% for females. So just some statistics on how that pans out. And then looking at suicide rates, I've got here the rates in 2020 by race, ethnicity in the United States. The highest rates are seen among non-Hispanic American Indians and Alaska Natives. So these are your Native Americans and Inuit peoples. They have higher rates of suicide. And I think that's where, when we were talking about Northern Canada and Greenland before, those are those folks, right? I think I'm not going to speculate too much on, why that may be. Personally, I think it probably has something to do with their cultures being so removed from them, and not having good connection with, consistent cultures and past, that may have a big thing to do with that, but not going to speculate too much on that. But those, we do tend to see higher rates in those populations. Next, non-Hispanic whites, so this Caucasians, um, tend to have the second on suicide for race and ethnicity. And so And when they're doing this in percents, this is the chart. If you look at it, it's the age adjusted rates per 100,000. So this is how many suicides per 100,000 of the population. And in the non-Hispanic American Indian Alaska Native, it's 23.9 per 100,000. For non-Hispanic white, it was 16.9. For non-Hispanic Native Hawaiian and other Pacific Islander, 12.5. Non-Hispanic multiracial, 9.6. Non-Hispanic black, 7.8. Hispanic, 7.5. And non-Hispanic Asian, 6.4. So those are rates of suicide per 100,000. And then this next chart, it shows between the years 1999 and 2021 the deaths per 100,000 of suicide per year. And what you'll see if you look at a chart like this is that the rate went up, pretty much went up every year, and peaked around 2018. And then it fell in 2019, 2020. I'm not quite sure I mean, we know COVID happened in 2020. Not sure why the number was dropping in 2019. Not sure if maybe we were doing something right there. And then rates have actually gone up since 2020. So they've then surpassed the 2018 rates. This chart only goes to 2021, but I've looked at 2022 and it's higher than the 2018 rates. And so I think the pandemic probably had an impact on kind of halting things maybe in a little bit, but then at the same time worsening them. And now we're seeing the rates go back up again. Not quite sure why, but the general trend is higher and higher rates every year. So I'd like to talk about pathophysiology next. So why does this happen, right? Why do folks get depressed? What is going on in the body? There's a lot of theories out there, okay? So, and I think there's a grain of truth to all the things on this list. And it, by person, you might have more influence of one versus another. So, just to go down through this list, and then I'm going to go in detail and kind of describe what we kind of know about this. So, there's likely genetic factors. So, if you have a family history of depression, it's more likely that you would get it versus someone who didn't. There's epigenetic stuff. So that's kind of, things that happened in the life of your ancestors. We think about, maybe your grandfather had childhood adversity, lived through a famine or something like that. And that affects his genetics that he passes on to the next generation, et cetera. So there's likely some epigenetic factors, environment. So that would be like if you're exposed to maybe toxins or pollutants, things like that. Diets, what you eat. I mentioned before about the metabolic syndrome and obesity. There's pretty clear evidence that if you have a healthier diet, you are more likely to not be depressed. I actually have a presentation. One of our episodes is going to be on this topic specifically, where I'm going to go through the studies on the links between diet and depression. So, exercise would also be in there. There is a correlation between exercising, cardiovascular health, and improved mood. And then moving down to kind of the next category would be the monoamine deficiency. This is the one that has been out there for decades, where, when people, you might hear, they have a chemical imbalance, or someone say, I have a chemical imbalance. This generally is thought to not be terribly accurate by today's standards. People likely do not have a chemical imbalance. That's not to say that there aren't some disorders where this might be playing a role, but for the most part, this is fairly debunked. It was generally thought in the past that this was the major contributing reason, and now it's a very minor. Um, and moving down the list, so altered HPA pathways, so that's your hypothalamic pituitary axis. So that's some hormone issues. Thyroid would be in there, cortisol would be in there, some of the endocrine disorders would be in there, or disruptions in that pathway likely has some contribution. Neurotoxic, neuroendocrine effects. So things that are causing brain damage in one way or another is likely to have an impact on mood. Um, Reduced GABA, that there's some thought that GABA is a chemical transmitter in the brain. We'll talk about it more in the anxiety lecture, but that may have something to do with depression. And then an impaired circadian rhythm is another kind of thought. So altered sleep patterns where people are not having a normal sleep wake cycle, that may also contribute to depression. Okay, now I want to go through kind of some more of the scientific details of what we currently understand about how depression happens. Okay, so the process of kind of, mood and depression is centered in the limbic system in the circuit of Papez. And likely contributing to this is you get atrophy of dendritic spines. So this is your dendrites are those are the branches on your cell bodies. So your nerve cells that are in your brain, the it's the kind of arms of it where it reaches out and touches other nerves. And atrophy means that they're kind of going away. So you've got a decrease in these connections in this area of the brain. And then you have a decrease of neurotrophic factors, things like BDNF, that's brain derived neurotrophic factor. And then you get reduced size of the prefrontal cortex, and that's the thinking part of the brain. That's the part in the front where we do a lot of our executive function and thinking. So reduced size there, reduced size in the hippocampus. That's where memory is centered, uh, and reduced size and decrease neuronal synapses in these areas. So, synapses are the connections between two different neurons, and so we have a decrease in these. And then a decrease in overall metabolic neuronal activity in the limbic system by 30 to 40%. So, in folks that have depression, these are physical changes that scientists that research this have seen in the brain. They see this atrophy of the dendritic spines. They see these reduced size of these certain parts of the brain, these decrease of certain neurotrophic factors, and the decrease in the overall metabolic neuronal activity. That means that your metabolic neuronal activity, that's the kind of energy engine that's going on, your mitochondrial activity, where you're like producing your ATP and your energy that's running the functions of the cell. We're seeing a decrease in that in these nerves in this part of the brain. Okay. So that's what we kind of see in the brain in folks that are depressed. Now, what's happening? Let's take an example of why someone might become depressed. So, first off, they're likely genetically vulnerable. So, this is somebody who likely has stuff in their genes, whether, their parent that they got it passed on from, their parents or whatever, or it was there was a mutation that happened, but they've inherited this in their genetics. And then they they encounter a stressor, so something stressful in life. They've had a breakup, or um, food scarcity, or uh, they're living in fear. They're in a dangerous environment. They're being harmed. Okay, so that some sort of stress has happened to the system in a genetically vulnerable individual, right? And then what happens is the limbic system goes further and further out of homeostasis. Now, homeostasis, that's where you have things in balance, right? And so the limbic system it's losing this balance. It's losing its ability to maintain the homeostatic nature of the system. And then we have chronic unpredictable stress, right? So these stressors that I talked about, they're happening over and over, or they're there and they're not going away. It's not like you have a little bit of stress, you deal with it, you go on, you overcome it. No, this is these stressors are mounting. The person is having a hard time overcoming them. They're having a hard time relieving these stress. And then what happens with stress? Cortisol is released. And then what happens when cortisol is released? You get a decrease in that BDNF I talked about earlier in the prefrontal cortex in the hippocampus. Okay. And then when this happens, we get a decrease in neurogenesis. Neurogenesis is that genesis, that's the beginning of things in the nerves, right? So the nerves are not growing. The connections that they're making, these healthy connections and strong connections, that this is being impaired. We're getting a decrease in this. The dendrite complexity, that remember the dendrites that we talked about, the complexity, they're not doing what they're supposed to be doing. They are not making as many connections. And then the spine density, remember the dendritic spines, those are the little tines that are sticking off from your nerve. In the prefrontal cortex, the density goes down. And then you get a hypertrophy in the nucleus accumbens. And the hypertrophy means an increase. And now the nucleus accumbens is getting more activity. And what happens in nucleus accumbens is this is where the whole kind of uh, cortisol system is being controlled by, right? And so then the limbic system function deteriorates to the point where the modulatory neurons, so these are the ones that are trying to help keep this other neuron where it's supposed to be, so that these neurons in the RAF nucleus, and that's where serotonin is, and the locus coeruleus no longer have the capacity to push the limbic system back into homeostasis. So remember, we've gotten out of homeostasis, and we've got this increased cortisol, this increased stress, and you've got your norepinephrine and your serotonergic systems, your dopamine systems, that we're going to talk about all these chemicals a little later. They're just not able to overcome this anymore. It's too much attacks on the system. And then the the depressive symptoms begin to emerge. And so some things that we've seen that can actually reverse this damage are ketamine, ECT, antidepressants, botulinum toxin, neurohormones like allopregnanolone, and there's some new medications that use that system, dietary changes, so increased omega-3 fatty acid intake, decrease in processed foods, whole grains. So improving your dietary, we're going to talk about that in subsequent episodes. That can help reverse this damage. Exercise can help it. Environmental changes, so life got better, things got better, right? So these are all things that we're going to talk about, a lot of these things, and how they can help reverse this damage. All right. And some moderating effects would be coping styles, so having healthier coping mechanisms, genetics. So if you've got genetics that make it more likely that you're going to be able to kind of overcome these things, that can help. And then the epigenetics. So if you've got kind of those positive epigenetics, or you've had the childhood adversity, like I said, with the grandfather, had some scarcity in food or whatever, that can moderate it in the negative direction. So what are some mediating effects? So these are some other effects that can affect this system. So the limbic hypothalamic pituitary axis alterations, reduced glucocorticoid receptor functioning, altered glucose tolerance and glucose sensitivity, excitotoxicity. So excitotoxicity is kind of, damage to the conduction of neurons. Intracellular calcium can be a mediating effect. Oxidative stress. So that's why people talk about antioxidants being good for you. Oxidation is typically a bad thing. It's something that we would want to reverse. So that oxidative stress can cause some problems in the system. Being in a pro-inflammatory state. And this is where I talked about with the metabolic syndrome. So metabolic syndrome, amongst many other things, puts you in a pro-inflammatory state that can have negative impacts on the system. Lower levels of counter-regulatory neurosteroids and pain. So a lot of stuff. And I think a lot of people, when I think there's a lot of people out there that will say things like mood and depression. Oh, it's just in your head. Like, no, no, it's not just in your head, and it's not just that you have a chemical imbalance of these couple of neurotransmitters. It's a lot of stuff. The brain is the most complicated. I mean, it's the most complicated thing in the universe that we're aware of is the human brain. It is, we know so little about it. And that's where this stuff is being controlled. And some of those things that I listed, those are things that we've been able to look into and say, hey, when this is, this way, it makes things worse. And when it's this way, it could make things better. It's not necessarily, it definitely will, or it definitely won't, but it tends to. We're really trying to understand this. And when you compare what we know now to what we knew 50 years ago, even 10 or 20 years ago, we've learned a lot. And hopefully, as we learn more, we'll come up with some better treatments, because the ones we have now are not quite what we want them to be. There's a lot of medications out there for other illnesses that cure people, that completely relieve symptoms. And the treatments for mental health stuff, for some folks, they get better, but not everyone does. And trying to understand, like, how is one person's brain different than another person's brain can help us to figure that out. And also, I think if you're somebody who's suffering from this, knowing that, it's not in your head, and it's not, this as simple as a chemical imbalance. It's a very complicated system, and we know very little about it. And we're learning more and more all the time. And that's why it's important to do this research, so that we can better understand it, and we can better customize our treatments and our therapies to each individual, so that things we can come up with the right treatment for each individual person. And I think it could give people that are suffering from this, and those that are maybe around people that are suffering from this, some better peace of mind. Oh, it's not my fault. It's not me. I can do something about it. Yes. But this is not a fault of my character. This is not, a fault of something about me. This is something that's going on chemically, and it's a very complicated in my brain, but there's things that we can do to fix it. And there's things we can do to make it better. And there's things we can do to make it worse. Things like drugs and alcohol, you know? And so that we can make better decisions on how to, because we all want to feel better, right? And we all like have these symptoms from time to time. We may not have the full-on disorder. We i think most people would benefit from a lot of the treatments that are out there. Now, medications I would reserve for those that are really doing poorly, but lifestyle modifications, and going to therapy, or doing the things that therapy can do to help you feel better. Those are things that almost anyone could do and improve their functioning in their lives. Okay. So, like I said, it's not this simple idea that it's a chemical imbalance or a monoamine deficiency. But there are a few things where we think that is at play. And these are things that are more like the person has like more of a brain insult. They have more of like a, a damage to the brain from something. So this would be like neurodegenerative disorders like Alzheimer's or Parkinson's, or alcoholic Korsakoff syndrome, epilepsy, so it's having seizures, tumors in the brain, stroke, multiple sclerosis, neurosyphilis. So these are things where like we're damaging the brain in a macro way. And so these are things where maybe you have a person that's doing perfectly fine their entire life, and then they have one of these things happen to them. It may be more of the chemical going on in that situation. But once again, still a very complex situation. So, kind of to continue on with the pathophysiology, the primary problem here is not in the modulatory system, it's in the end organ, which is the brain. And so, this is an analogy that I've heard that really, I think, can help this make sense to people and relate it to other disorders. So, say you've got heart disease, right? Heart disease is not a failure of the autonomic system, right? And the autonomic system is the system that's automatic, that keeps the heart, you don't have to think about beating your heart, it just happens. It's your vagal nerve, things like that are communicating to your heart what to do. So it's not necessarily a fault of that system, but if I give you a med like an inotropic medication like a beta blocker, that can help, right? And so the heart disease is actually more caused by the buildup of plaques and, you know occluding vessels and causing death to muscle tissue in the heart, right? Things like that. It's not the nerve system. And it could be, right? There could be situations where that autonomic system is impaired, but more than likely, heart disease is caused by these plaques and buildups and occlusions and death of tissue. And so, but what we're doing to help with it is we're giving something that interacts with the autonomic system of the heart, okay? Not necessarily the part that caused the problem, but the medication can help it. You think about the brain in a similar way. So the limbic system, the limbic, is like the mood, and it's a part of the brain. And we talked about it a few slides ago. The disease of the limbic system is not a failure of the chemicals, the monoamines, the serotonins, the norepinephrines, dopamine, right? It's not a failure of that system. However, taking meds that alter the levels of those monoamines can help. Okay, because I think in the past, we just kind of serendipitously found that this med that alters serotonin relieved depression in people, and we were like, oh, well, these people must not have enough serotonin, so giving them something that increases their levels of serotonin will fix the problem because they didn't have enough serotonin, right? So that's that idea of the deficiency of the monoamines, this old idea that is not really relevant in today's thinking, right? But that doesn't mean that increasing that serotonin might help with the system, just in that the heart was helped by the drug that helped with the autonomic system, but the autonomic system wasn't the problem. Okay. I think that's a good way to kind of think about how it's not a chemical imbalance, but in altering those chemicals, it can still show the benefit. All right. So, and when we talk about these medications, these antidepressants, they're not that effective. I mean, it's unfortunate, but only about a third of patients that take them will recover from their depression. Another third will respond, and a third will have no response, and many of them will feel worse, and some of them will feel suicidal. So you got a third of patients that basically recover means it's gone. I'm not depressed anymore. Respond means my symptoms decreased by a certain amount. I have less symptoms. They're less severe. I feel better than I did before, but I don't feel good. I haven't gotten over the depression. So a third of folks will get completely better, a third of folks will get a little bit better, and a third of folks will get no relief or worse. So not great. Not that. I mean, that leaves a lot of people that this treatment is not going to help them. So, and then also the positive effects that people have with the medications often don't last. When they stop them, they get worse again. Okay. And then just a word on ketamine and ECT, which, ketamine is not really an antidepressant, it's an anesthetic, but it's more and more being, tested and used as an antidepressant. And then ECT that's electroconvulsive therapy. So that's a procedure. Those actually stimulate synaptogenesis. So that's increasing the number of connections between nerves. They turn on a rapid response genes that activate structural genes in the limbic system neurons and start replacing receptors and transport systems within the cells. So they actually put the brain back into a state where it's not doing what it does that makes you feel depressed. And then regarding psychotherapy, life environmental changes, and improve resilience, which we can do through therapy or just, through self help, um, those effects actually are more likely to last longer, but they take longer to take effect. Now, this is a drugs podcast. I'm going to be mainly talking about drugs, but I think that therapy is likely a better treatment for a lot of people. Now, when we look at studies, therapy and meds show very similar rates of response. So you're just as likely to get better with one as the other. If you take both, you're even more likely to get better. But therapy is a lot less invasive. It doesn't have the adverse effects that medications have. It doesn't have a lot of the stigmas and other things that go along and things like that. And it tends to, if you respond to the therapy, it's more likely that you will continue to function well once the therapy stops. But it does take a lot more, right? It's easy to take a med and see your doctor once a month for a while, and then you feel better after a few months. But you've got to go to therapy, once a week, twice a week, maybe, for months and months and months, and work on things in the therapy and work on changing the way you think and behave and perceive things, and just kind of breaking that down. That takes a long time, but the effects are longer lasting.
Hi, Dr. Armstrong here. I'm just breaking in. I finished recording this first episode, and it ended up being about an hour and a half, which was a bit longer than I had planned on it being. And I didn't quite get as far as I had planned. So I'm just breaking in now to break up this episode into two episodes, so it'll be easier for you to listen to. So I really wanted to thank you for tuning in to this first installment of the introduction to antidepressants and depression. And I will be continuing on. And I think you're going to like this next half a little better. I get a little looser, getting a little more comfortable with the medium. Please stick in with it. I think you're really going to enjoy it. I'm really happy that you tuned in. And we're going to finish up the second half of Introduction to Depression in the next episode. And then after that, I'm going to start getting into the antidepressants themselves. So thank you so much for listening, and I'll see you next time.